My name is Candace Ping. I am a PharmD candidate at the D'Youville College School of Pharmacy. For my journal club, the title of the article that I chose was Fidaxomicin versus Vancomycin for Clostridium difficile infection. The authors are Louis, Miller, and Mullane et al. The source of the article was from the New England Journal of Medicine from 2012. The primary objective of this trial was to compare the efficacy and safety of fidaxomicin versus vancomycin in the treatment of Clostridium difficile infection. The primary efficacy measure of this article was the rate of clinical cure. The secondary efficacy endpoint was the recurrence of C. difficile infection during the 4-week period after the end of the course of therapy. The study design was that this was a prospective, multi-center, double-blind, randomized, parallel group trial. There were a total of 629 patients enrolled in the study, whom were men and women at least 16 years of age with the diagnosis of C. difficile infection. Inclusion criteria. Patients must have been at least 16 years of age, had the diagnosis of C. difficile infection, which was defined by the presence of diarrhea with more than 3 unformed bowel movements in the past 24 hours before randomization. They must have had the presence of C. difficile toxin A, B, or both in the stool specimen that was obtained 48 hours before randomization. Females of childbearing age were required to use adequate and reliable method of contraception, and postmenopausal women must have been so for at least 1 year. All patients must have signed an informed consent form and must have been using no other potentially effective concurrent treatment for C. difficile infection, except for up to 4 doses of metronidazole or vancomycin in the 24-hour period before randomization. Exclusion criteria included patients with life-threatening or fulminant C. difficile infection, patients with toxic megacolon, patients with previous exposure to fidaxomicin, patients who were pregnant or breastfeeding, patients who had a history of ulcerative colitis or Crohn's disease, or patients with more than one occurrence of C. difficile infection within 3 months before the start of the study. The study was conducted between May 9, 2006 and August 21, 2008. For monitoring, fecal samples for toxin assays to verify the infection and microbiologic tests were obtained at the time of screening or enrollment, at the time of early termination or end of therapy visits in patients with clinical failure, and at visits for the diagnosis and treatment of recurrent infection. Blood samples were obtained before the first dose of the study medication, 3 to 5 hours after the first dose of the study medication on day 1, and at the end of therapy or early termination visit. The primary analysis was done through both per protocol and intent to treat populations. Alpha and power were not mentioned, but there were statistically significant results. For the purpose of this journal club, I only used per protocol populations. The data analyzed was time to resolution of diarrhea from the start of the treatment until the last unformed bowel movement, and that was measured using the Kaplan-Meier method, which was appropriate. The comparison of resolution time curves was measured using the Gehan-Wilcoxon test, which was appropriate. Figure 1 below in the journal club shows the randomization and follow-up of patients in the study, and figure 2 below shows all the outcomes of the study. Other results were that the adherence to the study medications was similar between the 2 groups in the per protocol population, 95.8% and 96.1% in the fidaxomicin and vancomycin groups, respectively. There were also similar numbers of patients that had clinical cure and could be evaluated for recurrence in each of the 2 groups. The criteria for the non-inferiority with respect to primary endpoint, which was clinical cure, were met in both populations. 92.1% of the fidaxomicin group and 89.8% of the vancomycin group. Treatment with fidaxomicin was associated with significant lower rate of recurrence than the vancomycin population, which was 13.3% versus 24%, respectively. Treatment with the fidaxomicin resulted in statistically significant higher rates of resolution of diarrhea without recurrence than the vancomycin group, which was 77.7% and 67.1% respectively. The median time to resolution of diarrhea was shorter for the fidaxomicin group than the vancomycin group, 55 hours versus 69 hours. And adverse events that were possibly or definitely related to the two study medications were similar between the two groups, 9.7% and 9.0%. And there were statistically more serious adverse events related to lab testing results in the fidaxomicin group versus the vancomycin group, which was 4.7% versus 1.2%. And here's figures 1 and table 1, which just show the breakdown and how the study worked, as stated above. Safety was assessed from the day informed consent was provided through the last day of the last dose of the study drug. And physical examination, electrocardiography, and clinical laboratory testing, including blood and biochemical tests and urinalysis. No subjects discontinued the study due to intolerance or allergy of the study medication. In both groups had similar incidents of serious events in each system organ class, although there was a difference in the lab testing, as stated before also. And this chart is just showing the difference between the two groups and the adverse events that did occur. As you can see, they weren't very different other than the lab test. The serious adverse events that were reported included hyperuricemia, increased AST or ALT, leukopenia, azotemia, hypercalcemia, hypocalcemia, hyperglycemia, hyponatremia, hypophosphatemia, neutropenia, lymphonemia, thrombocytopenia, and increased INR. However, 16 of these 19 that were listed were unrelated to the study medications and were caused due to other diseases such as cancer, pancreatitis, or pneumonia. The 3 of the serious events that were related to the study medications were hyperuricemia and increased AST and ALT. And that information was taken from the supplementary appendix on the New England Journal of Medicine website. The author concluded that the rates of clinical cure of C. difficile after treatment with fidaxomicin was not inferior to vancomycin. However, fidaxomicin was linked to a lower rate of recurrence than vancomycin. The strengths of this study were the statistical tests. They were all appropriate, evaluation measurements, inclusion criteria and exclusion criteria, randomization, duration, dose, blinding, and conclusions. And the limitation of the study was power because it was not discussed, so therefore it wasn't set or met. This makes this article a level 2 level of evidence with major limitations. Based on the results of this study, I would not recommend fidaxomicin over vancomycin for the treatment of C. difficile infection unless the C. difficile infection is refractory with the use of other antibiotics based on the following considerations. There were similar numbers of patients that were clinically cured between the two groups. Also, there was not a significant difference in the time to resolution of diarrhea between the two groups. However, I would recommend fidaxomicin for the treatment of refractory C. difficile infection because fidaxomicin had lower rates of recurrence than vancomycin. So therefore, if the infection does not go away or keeps recurring, this may be a good option. There were no significant differences between the two groups in rates of adverse events or serious adverse events. However, with fidaxomicin, there were more events related to laboratory test results, but these are things that can be monitored. So I wouldn't say that it is an unsafe medication. Fidaxomicin costs $168 for one 200 milligram tablet. So for a 10-day course of treatment, a patient, it would cost them $3,360. Vancomycin for one 125 milligram capsule costs $30.09. So for 10 days, it would be about $1,200 versus the $3,300 for fidaxomicin. Vancomycin IV powder can be used orally for the treatment of C. diff, and a 10-day course of that would be $9.50. So that would be the much cheaper option. Fidaxomicin is only available as brand name, and vancomycin is available generically. Fidaxomicin is only available as tablets, while vancomycin is available as an oral solution also. Vancomycin has to be renally adjusted, while fidaxomicin does not need to be dose adjusted at all. Vancomycin is pregnancy category C, and fidaxomicin is pregnancy category B, which is something to consider for patients that are expecting to be pregnant or are pregnant. Vancomycin peak and troughs must be monitored, and fidaxomicin has no monitoring of labs or peaks or troughs. Vancomycin has a risk of ototoxicity, and vancomycin is contraindicated in patients with corn or corn product allergies. So based on these considerations, vancomycin would be a better first-line option unless one of the above special considerations leads to choosing fidaxomicin as a better alternative. Thank you.